Hi, everybody. Thank you for joining us today at Trevor and Jill Talk. We are so honored, really, to have today with us Dr. Faiqa Cheema. She is an infectious disease specialist at Hartford Hospital. She has a long and deep and amazing resume in infectious disease and some specialties. But right now, she is also concentrating on the COVID-19 pandemic, treating patients, and also getting the important information out to people that they really need to know. That's so critical. And so we want to share her expertise with you. We're thrilled to have her here today. Thank you so much, Dr. Cheema.
Thank you for having me. This is so important what you're doing to get the right and accurate information out to everybody. So I appreciate you guys. And this is such an important step that we're doing.
Well, Dr. Cheema, Jill and I have been talking about this quite a bit, which is we know that the FDA is approving as we speak Pfizer, the first vaccine to come out, Moderna is the next one. First of all, how long will this take to roll out? Who will get it first? And when can somebody like Jill and I end up getting a vaccine? How long do you think it'll take?
So the FDA will most likely approve and give emergency use authorization to Pfizer today. And in about another 10 days, Moderna vaccine, which is a second vaccine, will get authorization in about December 17th or December 15th. We don't really know the exact timing. When that happens, the vaccines will be allocated to the states, and the state health department will then decide how the vaccine will be distributed. We're hoping that the distribution will be done in an equitable and a transparent fashion. The FDA has sat down with a group of people, which is the advisory committee, which gives recommendations on who will be vaccinated first. And so far, the recommendations that they have made as a first tier group that will be vaccinated will be the frontline healthcare workers, as well as the nursing home residents and the people who work at the nursing home residents. Nursing home residents were fit into the first tier group because we saw that during this year of the COVID-19 pandemic, we saw a very high mortality rate of almost 40% in these elderly populations. So we're trying to keep them protected and safe. The second tier group will be the frontline health workers, such as the teachers, the police officers, and the firefighters. And the third tier group will be people in the vulnerable age population, such as age greater than 60 or 65, or those that have underlying immune compromised conditions, such as cancer or are transplant patients.
So I have a question. When you say all the frontline healthcare workers, will that be not only doctors that work in hospitals, but doctors that you go see for any cardiac reason, to have your mammogram, etc.? What does that mean exactly?
So, even in the frontline workers, we have a tier system set up. And the reason for doing that is twofold. One is that we're not getting we're getting the vaccines in limited supply. We're not getting a whole batch. We're getting a certain amount the first week, and then a little bit more the second week, and then a little bit more the third week. So we're unable, logistically to vaccinate everybody at the same time because we just don't have enough vaccines. The second reason of doing them in that tiered fashion is that we know that with this vaccine, there may be a couple of hours or maybe 12 to 24 hours that you may not feel that great. You may have pain in your shoulder. You may have a little bit of fevers or chills. So if we were to vaccinate all the frontline healthcare workers at the same time, they may not show up to work. And we can't have that in the middle of such a pandemic where the numbers are exponentially on the rise. Within the frontline healthcare workers, we have split them up with those who are the highest risk. Those are the people in the emergency room, which not only includes the doctors, the nurses, but also the respiratory therapists, the people at the front desk in the emergency room, the people who clean the emergency room. We've taken into account everybody who will be exposed to this virus at any time and point. And then we've risk stratified them from high risk to medium risk to low risk.
So is this something that you expect to be consistent state to state?
I believe that I think everybody is on board with trying to get people vaccinated, and they want to do it in a way that is transparent. And we all have the same goals of getting as many people as we can vaccinated quickly, because as you know that we're seeing COVID deaths to be greater than 3,000 per day. They've gone up to 3,100 today, and we're projecting that the number of deaths that can occur will be higher than 4,000 cases of death per day. So we're trying to avoid unnecessary deaths. So we're moving at lightning speed to get as many people as we can vaccinated. So by the end of next year, or probably around summertime, we're hoping that we'll get at least 30 to 40% of the people vaccinated. And then people in your age group or people who do not have underlying conditions, as well as the rest of the population around June, July, maybe fall, we'll really see a turnaround in how things are progressing with this pandemic.
So, Dr. Cheema, I'm aware that there are many different communities that don't trust the vaccine.
Mm-hmm.
I even heard from a friend of mine's high school son that he believes that there's a chip that's going to be in the vaccine, therefore he didn't want to take it. How do we deal with this challenge of building trust around it and getting this past? I don't know what the herd immunity is, like over 75%. Like, this is important, correct?
Yeah, that's a really great question. I think a lot of us in health and science are grappling with how we can get people to understand that this vaccine is very safe. But I agree. I think people would not really take the advice readily from healthcare professionals and scientists, because there's a lot of mistrust of science, as we've seen throughout this pandemic. And we're really going to have to ask community leaders, leaders of the church, young youth leaders to take the lead on this and to collaborate with us in science to get the message across that 95% efficacy or effectiveness is really remarkable. We're seeing history in the making. This is a time for celebration, that we want people to be safe. This vaccine is 95% effective in preventing two things: death and disease. So that's really, really impressive. We know that the vaccine has been studied extensively in terms of its side effects, and we know that we have found it to be safe. And we'll talk a little bit about that, because I'm sure a lot of people may have questions about the safety of this vaccine.
Well, actually, it's kind of interesting. Trevor and I have also talked about this a lot. I would go tomorrow, most likely, if they would choose me. But I do know that many of my friends are like, I really will take the vaccine, but not for a few months. And maybe they have in some ways, because I know yesterday they found that a few of the people that took the vaccine in the UK, especially that had severe allergies, had a bad reaction.
Mm-hmm.
So I had one question that came in, was somebody whose son has that situation, and they were very nervous about it, asking should they be then getting a different one of the vaccines. And I guess that leads to who should not take this vaccine right away. Are there conditions that, is it pregnancy? Is it allergies? What is that?
So far, the vaccine hasn't been studied in children. Now Pfizer has started a new trial in children 12 years and older, and Moderna is looking at the effects of this vaccine in between 12 years and 18 years of age. So hopefully we'll have that information in the next 2-3 months. We'll have a little bit more data, but as we know, the children are not in the first 3 tiers of being vaccinated. It's really the healthcare workers who have a good understanding of science, and as people see that within the first 3 groups, people are doing fine, taking the vaccine, not having really major side effects, they'll feel more comfortable coming around to it. From the recent side effects that we've heard with the Pfizer vaccine, of the anaphylactic reaction, where people got the vaccine and then had either drop in blood pressure or a severe reaction where they have to be treated for it, that was also just 2 people. That's very, very rare, and as we increase the number of people who are vaccinated, the percentage of that happening will even drop much further. So for now, I think
people. I'm sorry to interrupt. 2 out of how many?
Just
people?
2 out. I don't really. They didn't really share that information, but it was just a small number of people. But I feel that at least at this point, till we have more information, the recommendations have been that if you have any kind of food allergy or an allergy to severe medication where you need to be taking an EpiPen to prevent those reactions, then maybe you would not be in the first group or the third group of people who would be taking the vaccine at this time, and that's probably a better idea to wait.
What would you say to somebody who's pregnant right now? Would you suggest that they take the vaccine?
We're still learning a little bit more about the effects of this vaccine in pregnancy, even though initially in the trials, pregnant people were not included, but there were some women who didn't know at that time they were pregnant, and later on in the trials we got information that they had tested positive. They had a positive pregnancy test, so those individuals will be followed. So eventually we will have some data on the effects of the vaccine in pregnancy and in lactating mothers, so stay tuned. We'll have some more information by the end of summer, hopefully.
Mm-hmm. So here's something that I find extremely interesting, or that I really want to know. Once you get the vaccine, can you still be contagious?
So that's a great question. We're hoping that once you get this vaccine, because it's 95% effective, that hopefully your response or antibody response will be so good, so robust, that even though you can still get sick from the virus, so this vaccine doesn't prevent COVID-19, you can get the vaccine, but you can still get the virus, but you won't develop severe disease, and you won't end up being in a hospital, and you won't end up requiring to be on a ventilator, and you won't end up dying from it. So those are all good things. But at this point, we're hoping that because the response is going to be so good, that even though you contract the virus and the virus enters through the nasopharynx, that your body's response will prevent it from going down into your lower respiratory tract, which is the lungs, and maybe perhaps the antibody response will prevent you from transmitting it to other people. So that's the hope, but we still don't know 100%, which is why we're saying, even though you get the vaccine, we will still continue to wear our masks. We'll still have to continue observing, physical distancing, avoid congregating indoors till we have accurate information that this is something that is a positive effect of the vaccine, but this was not really studied.
So, Dr. Cheema, I actually was lucky enough to be able to listen to Dr. Fauci yesterday speaking to a Harvard alumni group, and he was saying the same thing. You need to keep a mask on even if you've got the vaccine. At what point will we be able to be out and in the world again, going to a Thanksgiving or a party or a wedding and not have to worry about wearing a mask? How long do you think it'll be?
Well, if it was up to me, I would be like, oh my God, this is next summer. Let's have everybody travel, and because I love to travel. But realistically speaking, if everything goes as planned and we can keep up with the production of the vaccine and also get people to really take the vaccine, I think if we get to 40% by April, March, we'll see a dramatic shift. And we need to get to above 17 above to get to herd immunity. So when we get to the point, which we're hoping will be by spring, we want to get kids vaccinated, or at least majority of the population vaccinated, so the kids are safe. We want to hopefully get to the point. But even then, I predict realistically that we will still be wearing masks most of fall, maybe winter of next year. So I know, but I hope I'm wrong.
But that will allow us to at least be out in the world more.
Yes, we will definitely see some things relax a little bit. I think some things will come back, like maybe a little bit of sport events. Hopefully, our focus is going to be to get our kids back in school full time. So we're really working. We have certain goals that we want to achieve. It won't be full time that our masks will be off, but I think we'll definitely see things open up a little bit. If things go as planned and there are no hiccups, hopefully by the summer or fall.
So, Dr. Cheema, I'm wondering for you personally, what has been the biggest challenge watching this process and handling what you're handling?
Yeah, I think I get asked that a lot, and it just gets me, really thinking about life. And, I think this COVID-19 pandemic has really been a true test of our commitment to our communities, and we've really stepped up, and it's really been an honor and a privilege to serve our communities through these challenging times. But it hasn't really lightened the load that all the frontline health workers carry each day and bring to our families. In March and April, there was really not a whole lot that we knew about the virus, but we were in the thick of it. We didn't have PPE to protect ourselves, and we separated from our families for months and weeks, and that really took a toll on us emotionally. With the second surge that we're seeing, and I have, so many of us are just exhausted and tired, and it's really taking a toll on us at so many levels. But we're still unwavering in our commitment to keep fighting the good fight, because we really want to overcome this virus. We want to see, we keep focusing on the light at the end of the tunnel. Even before the pandemic, people don't remember that the physicians and the frontline healthcare workers were in a state of crisis. And the American Medical Association has reported that one physician was committing suicide every day, even before the pandemic. And 44% of nurses have reported some level of feeling emotionally burnt out or emotional toll that their work was taking on them. Since the pandemic, 2/3 of us have taken on more responsibilities. We have new roles, new jobs. We're working longer hours. We're bringing work home. And some of us have been furloughed or have lost their jobs. So we've been impacted at a financial level as well, which a lot of people may not be aware of. So we're trying to do the best we can. I think I get by just focusing on the positive, however small it is. For me, it's the success of each day that I kind of recap as I drive home, just to get my thoughts together. It could be something as small as just holding a patient's hand, or just reminding them that they need to keep fighting and seeing the hope in their eyes. That just gives me some clarity of mind, and so I can return to work the next day with an open heart, and keep doing what I'm doing, just like the rest of us that are here every day on the front lines.
I mean, this is why I was talking this about you before. To me, and I think now, hopefully everybody, this is why there were people every night going outside at 7:00 to salute healthcare workers. I wish we could do that in Connecticut. We're a little more spaced out, but we feel it for you at every level, and everyone who's working in this is, every day what you're doing is incredible. So thank you so much. I hope that people will remember this always. I mean, I don't know who will ever forget this time period, unless they're 3 years old. And even then, you see 3 and 4-year-olds walking around with masks. They may remember in some way, but for all of us, our appreciation to this, and the people who've developed the vaccines, who are helping the COVID patients, who are putting themselves out there every day, it's amazing. So thank you.
Well, thank you for that. Thank you for your love. It means so much to us to have that kind of appreciation from the community. We don't expect it, but we feel it when you guys share your thoughts with us.
Absolutely true. I actually was wondering, because I saw today how so many hospitals are really running out of ICU beds, and how so many of them are so understaffed. What is the status in Connecticut and some of the neighboring states for that?
I think in Connecticut we're doing fairly well. We haven't reached or exceeded the surge capacity. What is good about at least Hartford Healthcare as an organization is that the frontline healthcare workers feel safe, because the organization has done a really good job of providing us with more than adequate PPE, which is very different from how things were in March and April. The other, thing they've done for us is that we have access to hassle-free testing. So once a week we can get tested, which is, just important. There's no long lines, there are no waits. So we have access to testing, which was a problem in March and April. For our patients, for ourselves, we have hassle-free PPE available to us that we're able to utilize. We don't have to keep reusing them. And we're doing a really good job in managing our bed capacity as well. And also, our frontline healthcare workers, we have, enough bodies who are able to take care, because it's like a limited resource. There are not enough ICU trained nurses, and if we lose them, a respiratory therapist to COVID, then we're truly stuck, because they're so specialized and trained in taking care of these patients that we run out of all options.
So may they get
Dr. Cheema, I want to just, it appears that the death rate is down relative to what it was in the spring. So it seems that you all have learned new ways to cope with this, or healing modalities. Could you describe a couple of the changes that you've learned from over time?
Yeah, that's a really great question. In the beginning, in March and April, the virus was at our doorstep, and we were just scrambling. We didn't really know what to do with the patients who were just showing up very late in the course of their illness. And our immediate impulse, because their oxygen levels in their lungs was low, was to put them on the ventilator, which was doing them more harm than good. What we've learned through the course of these months, in the past 10 months, is that we try our very best to avoid putting them on the ventilator as long as we can, because now we have some therapeutics and drug options. The most important one that we've discovered is not a new drug that has been discovered, but an old drug that is been proven in randomized controlled trial, which is the best way to do any kind of research, is steroids, dexamethasone, which is very, very effective in these COVID positive patients who come in with low oxygen. So we're starting the steroids early in these patients, and they're responding, and we're preventing them from being on the ventilator, and they're recovering and going home. Also, what we've learned is that with the new antiviral drug remdesivir, if you started very early on, in the course of the illness, patients respond to this and get better. So the patients are also getting better, recognizing their symptoms. They're coming in earlier to the hospital. We're starting treatment early, and we're definitely seeing them get better and go home. So the death rate has definitely gone down. So we've gotten better at treatments.
Are those drugs ever given to somebody before they come to the hospital?
No, because they have to be given through an IV line. You cannot be given orally. But now, just the past 2 weeks, the monoclonal antibody that the President Trump got has been approved by the FDA. So for patients who are not sick enough to come to the hospital, they can get this drug. It's also given through the IV, but we've set up a system where we, if they're COVID positive, we call them, we say, hey, you meet the criteria for this great drug, come to our hospital, we'll set you up with an IV line. It infuses over 1 hour. We watch them for another 2 hours afterwards, and then they go home and they feel better. And this drug does a very good job of decreasing the concentration of the virus in your body and boosts your immune system to fight it. So we've seen good response from it. It still needs to be studied a little bit more, but we're using it. It's been FDA approved, and people are doing well on it.
That's really comforting to hear that there's treatments and there's
Yeah.
death rates down, even though I sort of hope do not want to get COVID or have anybody I know and love get it, but
there's something to, will there ever be, I thought that this was going to be coming in October. It seemed like, okay, this will happen, and then I'll be able to see this person or that person in my family. A rapid test that's truly reliable that maybe you can do at home or easily have access to. Is that still in the works, or now that the vaccines are here, has that been sort of pushed to the side? I know there's some that NFL uses, et cetera, that.
I think people are still working on it, but they're trying to standardize it in a way where every time you use it, the result is accurate and can be replicated. I think that's what the problem might be, and has to be standardized. I think the test that might be the most favorable is this rapid saliva test that you do it, you test yourself. It's like a pregnancy test. You get the lines as a yes or a no, and then that if you've tested that you test is positive, you need to quarantine at home. I think there's the technology still needs to be perfected, but I think they're working on it a lot. But we still have to wait and see. But the gold standard still remains the PCR, which is expensive, is time consuming, and requires a lot of resources.
And really only captures that moment in time that the test is taken.
Yeah,
correct.
You may still become positive, or maybe.
Correct.
Okay.
And I think that's really a function of the virus. You have to have a certain amount of viral load for the test to be positive. And then it also depends on how the test is done. If the person doing the test is not doing it properly, then that's one of the reasons you can test negative. And the other reason to test negative is when it was done at that point in time, the concentration of the virus was just not enough to be picked up by that test. And that when you turned positive maybe 4 or 5 days later, it was because that's when the virus was just kind of peaking in your body and was detected by this test. So no test is perfect, but out of all this tests, the PCR is the gold standard.
So one of the questions I have, and there seems to be some confusion, is a quarantine period 14 days or is it now 10 days? Because I feel like the CDC has changed some of the recommendations.
Yeah, the newer guidelines came based on the period of infectivity. So the incubation period can be as short as 3 to 5 days, or can be as long as 14 days. So they've recommended that if you are exposed to somebody who has tested positive for COVID, and that exposure is also defined on the CDC website as close contact for 15 minutes without a mask, somebody you were hugging or kissing or sharing utensils, spoons, glass of water, or sharing a meal together, that would be defined as close contact. And they said you can definitely shorten it to 10 days because the virus should peak by 5 to 7 days. Or isolate, quarantine for 7 days, and if tested negative after day 5, then you should be okay to come out. Because the virus just kind of peaks between 5 to 7 days, maybe 10 days. 7 days is kind of the peak. And if you've tested negative, if at any point in time after day 5 from exposure, you can quarantine for 7 days and come out. And initially, March and April, this was the rule that we were following for all healthcare workers because we were in surge capacity. We needed our healthcare workers to come back. So all the healthcare workers who were positive for COVID, we were saying, okay, after 7 days, come back to work.
The other question I have for you is, are you identifying any genetics that we as individuals might have that would cause us to get a more severe version of COVID? Can we identify people who are more at risk?
I think so far we know that race is one of the biggest predisposing factor. In studies that have been looked at, African Americans and Hispanic have a 3.5 to 3.8 times more likelihood of dying from this, and higher likelihood of having complications and ending up on the ventilator. They're going to look a little bit more about the impact of diabetes, high blood pressure, and these are just risk factors that we also see in people who are obese and have genetic predisposition that we see in the minority population. But other than that, I think that is a real area of interest that the scientists are looking into, and we'll definitely have a lot more information in the next couple of months.
So a few other questions that, in fact, I got a couple of them a couple of times over. If you have a choice between Pfizer and Moderna, do you have a choice? Or is it pretty much, how will this work? Will I go to my doctor's office? Will I register? I know in Chicago, they're already registering people in the county. I'm from there. I know my dad registered. He's 85 years old. And so that he's on for, as they get, as they go forward, and he's just going to go whatever vaccine is available, right? He's going to get. And you say, I would prefer this one over that one.
In the beginning, we really want to have a choice. We're just going to have to go with whatever is available. Maybe 6 to 8 months, or maybe a year down the road, things will change. Or maybe 3 to 6 months, the advisory committee, which is a group that reviews all the vaccines, may come up with specific recommendations when there is more data that one specific vaccine is better for certain population. But both the vaccines, it's important for everybody to know, has been studied in minority groups, people above the age of 60 and 65, people who have diabetes and hypertension, and the number of people who were enrolled in both these vaccine trials. In Moderna, they had 30,000 people enrolled, and in Pfizer, they had 44,000. And this is actually the typical size that most vaccine trials tend to be, even in non-emergent vaccine cases. So where the scientists and the review boards that have looked over these trials feel that the number of people enrolled in these vaccine trials for COVID were more than adequate, and they had a very good distribution of people who had diabetes, belong to the minority group, to get the data, and both are 94.5 and 95% efficacious. So our recommendations is take any vaccine that you can get, because both of them have been proven to be just as good.
And your follow-up, your second dose is from the same, right? It has to be the same.
Correct. You cannot, they're not interchangeable because, the vaccine for Pfizer, the concentration is different. The Moderna vaccine concentration is different. And then the adenovirus, which is the AstraZeneca vaccine, works in a completely different fashion. So you cannot interchange them. The Pfizer vaccine is given every 3 weeks. The Moderna is given every 4 weeks. So, they're just different things. And if you get one type of vaccine, you have to complete the second one with the same type.
So I don't know, I'm not a scientist. I don't really can't say I fully understand it, but the science behind this is an mRNA, which is different from a traditional vaccine. Can you speak to that a little bit?
Yeah, that's a great question. So the mRNA vaccine is a new technology, and a lot of people have reservations about this because we've never really heard about this type of vaccine before. Traditionally, we take either a portion of the dead bacteria or the virus, either it's dead or attenuated or live, and we put it in a vaccine and then we inject it. This is an entirely new technology, but not new because we've been studying it for almost over a decade in making certain medications for cancer treatments and also for treatment of making vaccines for rapidly evolving viruses such as the Zika virus, the rabies virus, and also we studied this kind of technology for the flu, but we haven't been successful. So we've really just built on all this information that we've had for more than a decade, but we weren't able to develop a vaccine of this type. And the reason being that this type of technology is really, really expensive. And to get a vaccine into the public, we needed a lot of money, and the government had to really invest in this type of technology, which is why the pharmaceutical companies were able to take this route. The other reason why we were able to develop this vaccine very quickly is because traditionally vaccines have to grow in egg yolk in a specific culture. That takes weeks and weeks and months. This type of vaccine is just built in a lab, takes a couple of hours to a day or two, and then can be scaled up and standardized very quickly. The vaccine of the mRNA technology doesn't contain any genetic material. I know a lot of people have this concern. It's actually a protein surrounded by fat. So it doesn't have any additives. It doesn't have any mercury. It doesn't have any other additional material like the traditional vaccines were known to have. So it's a really pure form of a vaccine with a protein and a fat layer. And the fat layer is really made that way. So you think about it as an M&M, the outer heart coating keeps the chocolate from melting. So that's really what the fat does. It's a way to get the protein into our cells and through our skin into our body. And as soon as it enters the body, the fat kind of melts and the protein is released. And what that protein is a signal, and it sends a signal to the human cell to make only one part of the coronavirus, which is the spike protein. So there's no genetic material. There's nothing that is incorporated into our DNA. It's just a message sent to the human cell to make a part of the virus, which tricks the immune system in thinking that our body is being attacked by the virus. Our human body is really used to doing this. This is not a new thing our human body is doing, because in an average, our human cell receives more than 500 these messages every day, telling us to metabolize the cells, to process certain things, to send additional messages so that our hair can grow, send messages to different parts of our body. And once the cell reads these messages, they're like post-it notes, it kind of shreds it and obliterates it. So it's like, think of it as sticky notes that our human cell gets every few minutes. It reads those messages and then gets rid of them. So what it's doing is that it'll make, when it gets this message, it'll make the army or the cavalry of your body, the immune system, and then it'll make some memory cells. So when your body is attacked by the real virus, an alarm kind of goes off in your body. Hey, there's an intruder. And then the T cells immediately go to that side and say, I know this, I've seen this before. And then they immediately get busy in attacking the virus, and therefore it cannot spread from your nasopharynx to your lower respiratory tract to the lungs, which is what we're hoping which is what it does to prevent you from getting very, very sick, dying from this virus. And we're hoping that will be the mechanism that will prevent you from spreading it to other people.
It's so amazing. And that was actually one of the best explanations I've ever heard. And I hope, right? One of the most comforting explanations to people who are worried about it and don't understand why this came about so quickly and think something's weird like that. But I had heard that this technology was in development for years and years. And like now they finally got because of this, they got the money to let it
Yeah, it's just we have been trying to study it, and also we've been studying these virus family for since 2003 when we had the initial pandemic, which was the SARS pandemic, which is also a coronavirus, and then the Middle Eastern respiratory virus, which is another family of the coronavirus, which we had the pandemic in 2012. So we really have been studying the spike protein since 2002 because that's really what the virus uses to enter into our human cell. It's like the crowbar to how the virus enters, pries open the cell, attaches itself, and then multiplies and spreads quite rapidly.
So another part of
How are we?
the conspiracy theories out there, I'm sure you've heard this, that Bill Gates has been developing vaccines and he's going to profit. Well, in fact, Pfizer is not going to, I know they're not going to charge for this vaccine. Is that correct? I'm not sure about Moderna, but this is going to be free. If you choose to get this vaccine, you will not have to pay for it. Am I correct?
Yeah, that's what I've heard as well, that most likely it will all be free, it will be included, but things I don't really, understand the economics of it all, but we're hoping that this will be available free in a pandemic. So, our hope is to get more than 70% of people vaccinated and not have to pay out of pocket for this or be burdened with additional financial costs related to this.
Well, how long are they expecting? Is there information yet on how long they expect this vaccine to last? Is it an annual vaccine?
Mm-hmm.
And how quickly also does it take effect? Let's say I got the shot tomorrow. When am I safe to kind of go out and be exposed to COVID-19?
So, the influenza is a virus, so also a virus like the coronavirus, but it's a segmented virus. It's just kind of how it's shaped. And when you have a segmented virus like flu, it is very susceptible to changes every season caused by what in science we call antigenic shifts and drifts. That means that it can pick up a change in its structure and then become completely new, which is why we actually every year have to come up with a new vaccine, and we're really not very good at it because of the type of technology that we're using. And we're hoping that with mRNA now getting a boost, maybe we'll have a better vaccine even for the flu. The coronavirus is not a segmented virus, so it's less prone to having those shifts and drifts and or mutations. We're hoping, so far we haven't seen any mutations at all in the coronavirus, and we expect because of the way it is and the vaccine that we have, that our immune system may last more than a year to 2 years. We don't know if we'll need a boost response. We'll have to see and measure people's response to the vaccine as more people get vaccinated. So we'll have that information in a bit of time, but we're hoping at least the immunity will last at least a year or even longer.
Great. And for going out, let's say, would I be able to, I got the vaccine tomorrow. When can I feel safe, even with a mask, to, enter into more situations?
You are not effectively immune till you have the second shot. So, and you have to wait 1 to 2 weeks. We say 2 weeks. So you have to wait 2 weeks after the second shot of the coronavirus vaccine to feel immune. So you have to wait for 2 weeks after the second shot.
So you need to be very careful during this process as well. Like, don't feel like, oh, I got the first one, maybe I have a little more.
Correct.
Mm-hmm.
Yeah, and I just want to remind everybody that when you do have those response to the vaccine, I prefer not to use side effects. Those are just response to the vaccine, and that's a good thing because it just shows that our body has taken up the vaccine and is making the soldiers and the cavalry that will keep you safe. And that response will look different for everybody and may be a little bit more prolonged after the second dose, which would look like maybe pain in your shoulder. You may have some fevers, nausea, a body ache, some diarrhea, some vomiting. That will last 12 hours and at the most 48 hours. We're not expecting anybody to have these symptoms last more than 48 hours. And after that, you'll feel good and you'll get back to normal. And when you feel that response, that should be like, yes, I'm protected. So that's the kind of message we want to send people, that don't be disheartened. That's a good thing. Think of yourself as, hey, I'm getting back into things and this is going to be good for me.
all positive.
Yeah.
Well, thank you so much. I've learned so much, and as Jill said, that is the best description of the difference between
Thank you.
traditional vaccine and mRNA. Now I'll never be able to eat a chocolate without.
I see M&Ms are good for you.
Yes.
We knew that.
Yes.
We appreciate this so much. I, for one, I can like feel the cotton and the alcohol. I'm waiting.
Yeah.
So thank you so much. I hope we can have you back to update people in a few months' time that there's a lot more positive news. Really appreciate it.
Yes.
Anything else you want anyone to know before we sign off?
No, I just want everybody to just stay educated, be connected to the accurate information, check in on each other. This is a hard time for everybody. Avoid traveling if you can for the holidays. It's really important. It's really important that for the holidays coming up with Christmas and New Year, we really double down because really help is on the way. And there is a light at the end of the tunnel. We're witnessing history. This is remarkable what we're seeing. So if you have questions, reach out to your primary care provider, your doctors. Reach out to me. I'm happy to answer questions. But stay informed and don't be afraid. This is a safe vaccine. We all have to take it. The trajectory of our lives can change, but it will depend largely on our ability to take the vaccine. So let's get there. Let's unite on this. Keep wearing our masks. Avoid congregating indoors at a time when we're seeing close to 290,000 deaths in the U.S. from the virus, which is almost the same as the U.S. soldiers who perished in World War II, the 4 years. So that's really, historical numbers that we're seeing from a virus. So we can do this. Let's come out on the other side. If there's something you can do, go out there and do it. Engage your communities, spread the right message, connect with people. If you want to connect with me, I'm happy to do that as well.
I was just talking to a friend of mine, and we were sort of discussing this. And one of the latest books that Jill and I both love is Untamed by Glennon Doyle. And one of the things she says in it is,
Yes.
we can do hard things.
Yes, I love her. Yeah, I do love her. Yeah, I love her.
Hard things.
She's great. Yeah, we can do hard things. She was always like, hard is the new normal. So we can do this, and we're gonna get to better times. We just have to get on the same page and double down and check in on each other and help each other out.
Protect each other.
Yes.
Thank you so much. I feel like we have able to offer this show information to our listeners is amazing for us and for them. So thank you again.
Thank you.
Oh, thank you for doing this.